Hello to everyone. Thank you for your kind invitation. Here in Santiago, Chile, it's 11 a.m. So good evening for everyone and good morning for the other rest of the people. I have no conflict with this presentation. This is my personal background. I started with HTOs and DFOs in early 2000. I used Chomofix plates since 2005. In the previous time, I used the AO plates. I never used a full plate.
Pewnie będę mógł być u was, więc mogłobyś tam kilka wcześniej niż planowaliśmy.
I perform between 35 to 50 osteotomies around the knee per year. Most of my osteotomies are open wedges, and almost 30% of my surgeries are combined surgeries with ACL and PCL reconstruction, chondral resurfacing, or meniscal allograft transplantation. Also, I see the other side of the story. I do also knee arthroplasties. This is my numbers per year in the last 10 years. So maybe when we're speaking about this difficult surgery and my lecture tries to speak about complications, let's try to do something to how to avoid complications in knee osteotomy. Maybe this is more important to the surgeon who is starting with that technique. So the topics we touch in that lecture, we'll search for the groups at risk that some of the previous speakers have showed. We will see the complication causes. We'll talk about surgical factors and how we can respect the lateral quarters to avoid fractures and to avoid no union on mal surgery. And I was saying he's obese. This patient had a medial osteonecrosis of the femoral condyle. The patient was treated elsewhere and they did this osteotomy. If you see on the left photograph, we see intraparietal photograph of an open wedge over 12 millimeters. This is a poodle plate, non-locked, and they use a sort of substitute, a synthetic substitute. This is the X-ray at 3 months. You see a collapse of the osteotomy. And this is how I received the patient in my office. So here we see an obese patient with a small implant, with a wrong technique, and that's how the story ended. With a total knee replacement, the osteotomy was almost healed, but we need to use a knee replacement with a short cemented stem. The patient is out of pain. It's been out for 6 years and is still working in the minor industry. So most important, and what kind of complications do we have is how we can do or perform a procedure without higher risk. So first of all, we will find what are the groups at risk. And we are Occidental people, and this is the United Kingdom registry for knee osteotomies. And we see there are two main groups. We got the younger patients who maybe come for malalignment, congenital disorders, or post-traumatic deformities. These patients, they tend to be healthy. They are low comorbidities levels, and these patients are younger. The other group is patients that are coming for osteoarthritis. These patients are over 50 years or 45 years. Most of these patients are obese, and they have a higher rate of comorbidities. And we see the weight of the patients. We see that almost 4/5 of the patients who are coming for a knee osteotomy for osteoarthritis are obese or super obese. So we need to take care about that, and we will need to know that maybe obese patients are not a contraindication because we'll take mostly of 50% of the patients out of the surgery. So if we see the number of complications that we have, I will try to get this publication for Nika Mendola, that we find that the most common complication causes are cortical hinge or articular fractures, unexpected undercorrections, hardware failures, and delayed unions and no unions. But if we compare the rates of complications with the small poodle plates of the first or the second generation and the Chomofix or the long locking plates, we'll see the complications with small plates are almost twice than the big plates. Another issue is about when you are comparing complications from closing wedge or open wedge in HTO. And we'll see that maybe the numbers are equal, but the severity of the complications is most importantly closing wedge, because a number of these complications are due to the technique. And we see peroneal palsies or peroneal injuries. And these injuries are quite severe and they can disturb the whole life of this patient. So if we compared open wedge osteotomies with closing wedge osteotomies, we need to know how they affect the patellar height or the posterior tibial slope. We must know that if we are doing a closing wedge, we are increasing the patellar height. In the opposite, if we do an opposite wedge, an open wedge, we will decrease the patellar height, but we need to use the Caton de Champs index because the Salberstein stays stable during the time of correction. So there's no change in that. The other thing that we know is the number of grades that we change or millimeters that we change under the osteotomy is not important if our correction gap is less than 10 millimeters. Also, we know that if we're doing an open wedge, we are increasing the slope by 2 to 3 degrees if the correction is under 10 millimeters. And if we are doing a closing wedge, we are decreasing the posterior slope by 3 to 4 degrees if the correction is less than 10 millimeters. So these factors we need to know, and we need to check our patient's patellar height and slope before the procedure. This is a study from the group of Andreas Himhoff. He compared the slope change in patients with closing wedge and with open wedge. And he also compared how locking plates are different compared with the poodle plate. And they saw that slope is increasing if you're using a poodle plate. Mostly if you place the plate in the anterior area of the cutting surface. So it's more sensitive and it's more, I think, wise to use a plate that doesn't come with blocks. So your correction gap will be what you measure or what you see in the preoperatively or postoperative protocol. This is another study from the Japanese literature, and they found the same results, that the slope is changing with the open wedge osteotomy, and the Caton de Champs is decreasing when you're using an open wedge. But if their numbers are less than 10 millimeters, this is not important for the follow-up of the patient. Another issue is the fractures of the lateral hinge in the open wedge osteotomy. We see that with the A in the figure of your left, this is an ideal point, 15 to 20 millimeters from the articular surface. And in this study, they check what happens if we are choosing or a spot for the hinge is below that. And they found that will increase the posterior slope. That will increase the magnitude of our correction. So we need to check intraoperatively that we have done preoperatively. If you use the same landmarks that when we studied before the surgery, this patient will end with an overcorrection. And also we see there's a higher rate with lateral hinge fractures if we put a lower hinge point. On the other hand, what happens if we are increasing or decreasing the slope? And in contrast with the previous speaker, I don't do changes in my slope if the patient have an instability. Why? Because if we're increasing the slope, the wear and the load on the posterior area of the tibial plateau will increase. If we are thinking in young patients with ACL or PCL reconstructions who have received a medial meniscectomy or a medial repair, we will increase the wear and we increase the load over this meniscus. So this patient will finish with pain and with problems. So here we see a patient who have a 10 years PCL rupture. We see that the patient got a constitutional varus, and we see on the left image, in the right image, that the tibial is subluxated posteriorly. So in that patient, we did an open wedge HTO without changing the slope, and in the same time, a PCL reconstruction. So we are dealing with deformity and instability without changing the slope and without harming the wear of the tibial plateau. Here's another patient. This is sort of different. This is a third revision of an ACL reconstruction. This patient have a subtotal meniscectomy, but the patient has 23 years old. So we did an open wedge high tibial osteotomy and a revision of a reconstruction with an autograft of gracilis and semitendinous. And this is the radiograph result after 8 years of the surgery. Fractures have been divided and been classified by Takeuchi. We can have these 3 types, and type 2 is more related to delayed union. But also in the closing wedge group, we can find fractures of the hinge. And these fractures are not easy come. They also have complications. As we see in the right graphic, we'll see that type B, who are the number D that I'm pointing here, they have a higher rate of loss of correction and a high rate of non-unions or delayed unions. So it's not just for the open wedge HTOs that a fracture will harm the union rate. It's also for the closing wedge. First, this study is very important because there are many patients who have lateral hinge fractures and we don't know about them because we are using just regular sets of x-rays, and rotation sometimes will hide the fracture. So when under a suspect of a lateral hinge fracture, we need to use a CT scan. As we see in the graphic, we found 30% more fractures with a CT scan. But more important of that, we found that one of the main predictors for lateral hinge fractures is that when our correction is over 13 millimeters, there's a higher risk of this fracture. So we need to take care when we got higher corrections. And this is another study from Korea that also showed the same findings, that over 50 millimeters of correction, there's a higher correlation with lateral hinge fractures. We need to take care when we deal with corrections over 12 to 13 millimeters. But in the femur, we got the same feature. This cadaveric model told us that the ideal point to do a closing wedge femoral osteotomy is up to the femoral condyle. So it will be easier to do the fracture and to do the osteotomy. But this is cadaveric. And in the clinical setting, this other group from Korea also found if we take a point higher of the lateral femoral condyle as a hinge, this will increase the rate of fractures, and this will increase the rate of instability of the osteotomy, as we see in the left image. And this will be a very difficult surgery, and this will be also a very difficult to fix and to correct how we predicted before the surgery. So my recommendation is always use a hinge in a closing wedge of osteotomies under the femoral condyle and into the metaphyseal bone. As we see in this image, we use an up point to the osteotomy, and we see a small fracture that happened there because this is a weak bone. What happens with the open wedge femoral osteotomies? We see this excellent work from Andreas Himhoff group. We see the ideal place where we do our hinge, as we see in the figure on your left, and they describe 3 fractures of the medial hinge. A proximal, at the level, and below. It's the same like Takeuchi's. But using a long plate and a Chomofix plate, there were no changes in the outcomes with these patients. Why? Because a very rigid and fixed plate. But what they found, if the point where they put the hinge is below the adductor tubercle, the rate of fractures was very low compared it was proximal to the adductor tubercle. So always when you use an open wedge osteotomy of the femur, please use a hinge below the adductor level into the metaphyseal bone. So we will be safe and the chances to have a fracture will be very low. As we see in this patient who is absolutely healed after almost 8 years of the procedure. So as the previous speaker said, smokers and unstable lateral hinge fractures are predictors to have a delayed gap filling on an open wedge HTO. But early full weight bearing has not implications on the results. So these plates, when you're using Chomofix, are very strong. So we can allow full weight bearing from the first moment that we do the surgery. Obesity, there are controversial indicators. Andreas Himhoff showed that it increases the non-union rate in open wedge distal femoral osteotomies, but Lobenhofer, Staubeli, and other searches, they didn't find any influence in the outcomes and complications if the BMI is below 30. Here we see a patient that's an obese patient, a smoking lady of 32 years, after she got a valgus deformity of 13 degrees. We did a femoral osteotomy, and there was a delayed union, and she healed after 1 year. But we didn't need to have another surgery. She healed well, but very long. So we need to wait in these patients. Most of the time, we need to add another surgery, like we have to do if we have small plates or weaker plates. So is it important the kind of plate that we are using? My answer is yes. This classic article from Bruce Millin and Edward Wojcicki, they've shown 37 to 40% of complications after an HTO. But if you see in the graphic on your right, most of the plates were very small plates and there were non-locked plates. So this classical article from Staubeli and Philip Lobenhofer in 2003 find the first results of the tomofix at the HTO. What they find in that article is that the correction remains stable after the first year of postoperative recuperation of a patient with an osteotomy. So they showed that the plate is very rigid, it's very secure, and there are very, very, very small rates of non-union and further displacement. There are a couple of biomechanical studies that show comparing the poodle plate and the tomofix, and they found there is less displacement with the tomofix than the poodle, and the construction that we do with the tomofix is more rigid. Some concerns have been placed about healing in the tomofix plate. This is in biomechanical studies. On the clinical studies, most 98%, between 96 to 98% of the patients with no graft are healing after an open wedge HTO using tomofix. And as we see here, full weight bearing from the first day of the surgery doesn't harm the further protocol. In the other way, patients who are more motions and more activities, and we allowed full weight bearing or progressive weight bearing after the surgery, got better functional outcomes at 6 months after the surgery than a patient that had been 3 weeks or 3 months or 6 months in some cases without load. This is an excellent article from the Korean literature, and they found what happened with the patients who have a lateral hinge fracture. So first, using the tomofix plate, there were no changes in the outcomes on the scores. Second, in a group of 4 surgeons who are dealing with HTOs, they found a constantly relevant equal number or percentage of lateral hinge fractures, around 20%. So it remains constant, mostly if our correction is over 10 millimeters. But the most important finding when we have a fracture is that the most of the osteotomies healed, but they have a delayed healing of 2 months in average. So a regular HTO with a non-fracture of the hinge got a sort of 5 months from the moment of the surgery that it heals radiographically. If there's a fracture, the average is around 7 months. So what's happening at time? What happened if we're following our osteotomy through time? We know with small plates, most of the cases have a short displacement or loss of correction over the time. And that loss of correction is increasing if our correction gap is over 10 millimeters. What we find with locking plates or tomofix, that the correction it remains stable, as we see in the graphic on our left, is group 2, over the time up to 1 year. So almost no angular loss after 10 millimeters of correction after 1 year. So that seems that the plate that you choose, it's crucial for the follow-up of the patient. So what happened with bone graft? Well, there are a number of studies that show there's no difference in gap filling anytime, any kind of bone graft that we use, autologous, allogenic, or bone substitute. But the most important of all, that using a stiff plate like Chomofix graft in HTO is not indicated if the correction is under 14 millimeters. I don't use bone graft, I think, since 10 years ago for any patient. I have no new news in my number of patients that over 250. So in summary, to prevent complications, you need to check your patient and improve the comorbidities mostly in the older ones. You need to plan your osteotomy, but you don't have to stay strict with your plan. You need to check intraoperatively what will be the later alignment of the patient. You need to check the patellar height, the slope, and the stability to prevent that and to have or add instability reconstruction at the same time. You need to prevent hinge fractures with recommendations that I and the other presenters have to give you. And in an open wedge HTO, you need just to use graft if correction is over 13 millimeters. And in an open wedge distal femoral osteotomy, I always use graft. It has been demonstrated that over 7 millimeters of correction on the femur, you need to use any kind of graft. Later, why not to choose a locking plate? If the evidence has that a better plate allows you to move your patients quickly and to have more securities, you need to choose a locking plate. And safety and outcomes are relevant over plate extraction. Thank you very much.